Welcome to the New England Journal of Medicine at the annual meeting of the European Society of Cardiology. I'm Stephen Morrissey, Executive Managing Editor, and I'm talking with Deputy Editor Jane Leopold and Editor-in-Chief Eric Rubin. We're looking at the Oceanic AF trial, Asundexian versus Apixaban in patients with atrial fibrillation. This study asked about the optimal therapy to prevent stroke in atrial fibrillation. Jane, why is that important?
So Asundexian is an activated factor 11 inhibitor, and it's interesting in that it can potentially reduce thromboembolic events while lowering the risk of bleeding. And so this was looked at in some earlier studies, but this hasn't been looked at in a phase 3 trial.
Eric, how was the study done and what was the outcome?
Steve, this was a non-inferiority study which compared participants who took Asundexian with those who took Apixaban. The patients were those people with atrial fibrillation and a high risk of embolic disease, and they were randomized to receive either agent. The primary outcome was stroke or systemic embolism. The investigators also looked at other major bleeding events as a safety outcome. There were almost 15,000 participants. The trial was stopped early when the primary endpoint was reached in 1.3% of those on Asundexian, but only 0.4% of those on Apixaban, results that failed to show in non-inferiority. However, there were fewer bleeding events on the Asundexian.
So Jane, given the positive findings with the phase 2 Pacific AF study, how do we put the results of Oceanic AF in context?
Yeah, that's a very interesting question. So from the earlier trial, we knew that the Asundexian dose was tolerable to patients and that there weren't an excess of adverse events. But what we didn't know was in a large randomized trial, what would happen. And so this study, and this study being stopped early, I think was a bit of a surprise. And the fact that this was stopped because of an increase in systemic embolism or stroke in the Asundexian group was also surprising. So here we have to think about potentially why that could have been, whether this was a dose issue, whether this was a systemic issue in terms of the drug and drug metabolism, or whether or not there were adverse events in a group of patients and whether there may have been subpopulations of patients who were benefiting versus who didn't. So we look forward to learning more about this.
Jane, it's a really interesting study, and it illustrates the difficulty of extrapolating from small studies to larger studies. And we think of dose selection as a relatively boring topic, but in this case, they may have missed their risk-benefit ratio, as we saw that the risk of embolism was higher on this dose, but the risk of bleeding was lower, and so they probably had more room to go. So do you expect another study using this drug or something like it?
Well, there are other studies out there of factor 11A inhibitors, not particularly this drug, but I think the door is not shut on this pathway, but the door may be shut on this drug.
Thank you, Jane, and thank you, Eric. This study was just published at NEJM.org.